Welcome, everyone. We'll just give it a few more minutes before people join, and then we'll get going. Okay, I think we can get started now. So welcome, everyone. My name is Richard Scone-James. I'm the head of programs at the Tropical Health and Education Trust. And today I'm really delighted that we're looking at climate crisis. We're calling this session Going Green. And we're looking at it in the context of global health, and we'll move to discuss how health partnerships and FETs can address and reduce the impacts of the crisis. And I'm delighted to be doing this with three speakers. So we're joined by Dr. Renzo Ginto, who is Associate Professor and Inaugural Director at the Planetary and Global Health Programme. He's based at St. Luke's Medical Center, College of Medicine in the Philippines. He is also the Chief Planetary Health Scientist at the Sunway Center for Planetary Health in Malaysia. And Renzo will be giving us the context of the climate crisis from the Southeast Asian perspective. We'll then hear from Jessica Beagley, who is an independent consultant who wrote the position paper entitled Health Inequalities and Climate Change. And this was produced by Action for Global Health. And it came out, I think, a few weeks ago now. So we'll hear about the findings from that paper and the recommendations for actors in global health. And then finally, we'll get the health partnership perspective from Dr. Elizabeth Tissing. Liz is a limb reconstruction surgeon at Oxford University's NHS Foundation Trust, and she also works with King's Global Health Partnerships as their partnership lead for the Democratic Republic of Congo. Before we go to the speakers, I'll just say a few words and try and set the scene and talk a little bit about FET's work so far. Obviously, we're 3 weeks away from the start of COP26, where our leaders are being encouraged to strengthen their nationally determined contributions towards accelerating action towards the goals of the Paris Agreement. So to try and bring the interventions to bring us more in line with the 1.5 degrees Celsius temperature rise rather than the 2 degrees Celsius that we're currently on track with. And of course, the health sector plays a huge role in this. And there are several meetings involving health and climate change at COP. And last month, of course, 200 health journals came together to publish an editorial calling on leaders to take emergency action on climate change and to protect health. So it's really fitting that we're meeting today to discuss this issue. And I'd really like, if we can, to get really practical about how health partnerships can contribute to these areas. And I really see there's two broad areas where the health partnership world intersects with this. So one is around resilience and adaptability. So helping health systems become more resilient to climate-related disasters, and working to address the evolving disease burden that we're seeing. And I know some of the speakers will speak to that directly. And then the other broad area is our impact as the health sector on the environment and how we can reduce that. So the 2019 Lancet Countdown on Health and Climate Change reported that the health sector is responsible for 5% of all greenhouse gas emissions, which is a huge figure in absolute terms, 5% of global emissions. And of course, there's already a ton of work going on. So the NHS has reduced greenhouse gas emissions by 26% already. And NHS England, for example, have introduced the Greener NHS programme, which is aiming to deliver the world's first net zero health service by 2040. And staff within the system clearly support this. So in a survey carried out by Greener NHS, 98% of NHS staff surveyed believe it's important for the healthcare system to support the environment. And I would posit that we as a health partnership, as a global health partnership community, we can't operate blind to that target. We can't have NHS staff working towards that target within their home institutions, within their employer institutions, and then disregarding that when we go overseas. So we have to be cognizant of those frameworks and processes that our partners and colleagues are working towards. So we have a political or organizational incentive. We clearly have a moral obligation. And I think it was Professor Suleiman Huq was saying earlier that, this is our tackling climate change is one of our greatest opportunities to achieve equity and sustainability in universal health coverage. And I would say there is another incentive, which is more practical, which is the funding environment. So we're all aware that the UK government slashed official development assistance from 0.7% of gross national income to 0.5% earlier this year, and we're not sure how long that will last. We don't yet know the details of the upcoming international development strategy, which is soon to be published, but I would suggest that FET and the health partnership community, we could expand our horizons for funding, and certainly there will be hopefully more funds available within the climate crisis world. So that's a little bit of a context setting. I just wanted to share my slide now and talk through what FET has been doing. If that's coming up for us now. And hands up, we don't have our own house in order at all on this. So it's very much baby steps at the moment. But a year or two ago, we set up an internal working group to look at every aspect of FET and our impact on the environment. And it's a team that I'm heading up at the moment. So internally, we have now started to audit our environmental impact. So looking at greenhouse gas emissions from international travel and energy use in the office. We're of course trying to ensure minimal waste and reuse, reduce and recycle where possible. And we're starting to incorporate an environmental assessment of travel as well as a financial assessment. So anytime we travel, we'll look at the cost benefit of how much it costs financially against the benefits, but we're also now going to include how much it costs environmentally as well as financially. And I was struck when I was preparing for this about a quote I read in the National Geographic the other day by Peter Kalmus, who's an astrophysicist and NASA climate scientist, and he said that hour for hour there is just about nothing you as an individual can do that's worse for the health of the planet than to sit on an airplane. And he goes on to say the hard fact that most people haven't accepted yet is that we don't need to fly, and if you truly accept that we're in a climate emergency, you shouldn't. And I know all of us are aware of the impact of flying, but sometimes it's worth being pointed out in stark terms like that. And of course, there's an ongoing educational staff needed for any kind of change process. We need all the staff on board for real change to happen. Externally, we've employed a bit of a carrot and stick approach. Stick, some of our grant holders will be familiar with. We have introduced a requirement that all international trips will have to last more than 3 days just to make the most of that international flight ticket. But the big step change for us was going to be the UK Partnerships for Health Systems grant programme, which we launched last year and unfortunately was cancelled due to the ODA cuts. But within that programme, we had set up a grant stream purely focusing on climate crisis. And this was the first time we'd ever done anything like this. And we asked health partnerships to focus on one of three areas. So the first was capacity building, focused on equipping health workers and services to provide effective service delivery during climate-related crises, i.e. resilience. The second was establishing or improving existing information systems, allowing for the collection of timely and relevant data on the incidence and geographic range of climate-sensitive outcomes. And the third was mitigating the health services environmental impact. We had to close the program before the deadline for the call for applications, so we don't even know if anyone was interested in this call, let alone what ideas health partnerships had. So I'd be really interested if anyone would like to say at the end, after the presentations, or indeed they can email me, just to let us know whether you were interested in school and what ideas you had, because that will give us an idea of the appetite for this kind of work amongst the health partnership community. And then finally, we're trying to accelerate our use of digital technology. We hired a full-time digital engagement officer to support this, and we'll soon be producing a resource for health partnerships around digital engagement, and this will outline best practice and principles in using digital technology in for learning, and signposting health partnerships to these kind of platforms and resources. And of course, as many of you are familiar with, we launched a online platform for anyone interested in global health called Pulse Partnerships. You can get to it at pulsepartnerships.org. And it's a place with several forums on various themes for global health, people to interact on. There are, again, signposts to online resources for online learning. And then there's various opportunities to get involved in virtual volunteering in the global health world. We've got about 500 active users, but when I looked yesterday, we have 998 actual users. So if you want to be that 1,000th member, then do go ahead quickly and sign up. So just before I hand over to our speakers, I wondered if we might try and make this interactive. We'll see how this goes towards the end of the session, but I have a few questions that I'd really like to hear from delegates about. So just if you could ponder these questions while the speakers are talking. So first is, what is the appetite for health partnerships to focus on climate crisis mitigation, resilience, and or adaptation? Do you feel like this is within the scope of your partnership or not? And in which of these areas do health partnerships feel equipped to focus on? And relatedly, what additional expertise do we need to bring to the health partnership community to achieve that? And finally, and more broadly, kind of how can FET support health partnerships to address and reduce the impacts of climate crisis? What can we do to get us moving on in this area? And yeah, if you have any thoughts afterwards, please do email me at richard.sconejames@fet.org. So I will stop there. Thank you for listening to me on that. So we will now hand over to our first speaker. I'm delighted that Dr. Renzo can join us. Renzo, over to you.
Thank you very much, Richard, for this opportunity. Good evening from Manila. It's already 6 p.m. here, but I guess this is the new normal in terms of convening, and especially after listening to Richard saying, mentioning the need for low carbon, conferences, convenings, meetings. I think this, we're really walking the talk here. Can you see my slides now? Just want to make sure, because now I can't see you.
Yeah, we can see. Thanks.
Wonderful. So I was tasked to give a brief overview of the climate and health situation where we are in right now. Of course, Richard already gave us some initial insights. And I just want to remind all of us about this important report, the 6th assessment report of the UN Intergovernmental Panel on Climate Change that was published more than a month ago. And basically, the IPCC said that we are already, the way they describe it is we're on code red, meaning the situation is really, really quite delicate and serious. As you can see in this, quite creatively done maps, every region of the world is already experiencing extreme weather, hot extremes, heavy precipitation, and many other wide, diverse range or array of climate-related impacts. And so we really live in very tough times even in the time of a pandemic. And I will not belabor you with the details of this diagram. You can Google this from the Lancet Climate and Health Commission's report in 2015. But basically, the lesson is that, or the key messages are that one, there are multiple pathways that link climate change with human health. And as a physician, I'm certainly very concerned about how climate change is going to impact the health of my patients, but also the health of broader communities and populations. As you can see, multiple arrows there, from storms to drought to flooding to heat waves, all of them leading to a wide range of health impacts. As you can see on the right, there's no single disease group that is going to be immune from the impacts of climate change, whether they are infectious diseases like mosquito borne diseases, dengue, chikungunya, Zika, malaria, or waterborne and foodborne diseases, chronic non communicable diseases, for instance, heat stroke when you get exposed to extreme heat, or cardiorespiratory illnesses coming from exposure to high levels of air pollution. The Lancet also, concluded that we can anticipate a 50 years, worth of nutritional gains to be reversed if climate change will not be averted. And of course, there's a growing science around the impacts of climate change on mental health, both through the extreme weather events when there is a typhoon, for example, in the Philippines, or a hurricane in the Caribbean. You can expect mental stress being experienced by people, communities who are forcibly displaced from their homes, especially traumatized children, all the way to the more slow onset effects of climate change on mental health, such as the newer concepts of eco anxiety and climate grief, ecological grief, that have been that are starting to feature in the medical and psychiatric literature. And as you know, I come from the Philippines, a country that is at the heart of the climate crisis, frequented by 20 typhoons each year, now growing in intensity and number frequency as well. But also, like all the countries in the world, we are still fighting this current pandemic. The situation is far from being stable, with the slow vaccine rollouts to the new variants of concern reaching our shores. And the Philippines has experienced for the past year and a half the confluence of the climate crisis on one hand and the COVID crisis on the other. As you can see in this photo, poor Filipinos are faced with the dilemma. On one hand, do I stay in our house, safe from the unseen coronavirus, but perhaps our house might get inundated or will get inundated by extreme flooding, or the roof might be blown away by the strong wind. Meanwhile, if you move to these cramped evacuation shelters, protected from the typhoons and the flooding that climate change is bringing, instead, you are encountering a very high risk of getting COVID, because, as you can see, there's no social distancing to begin with in these temporary shelters. And of course, it's not just the climate related disasters, extreme weather events that the Philippines has been and continues to be experiencing, but also the more slow onset effects, of course, increasing temperature, but also one area that requires more attention, especially for archipelagic countries like the Philippines. We have some of the longest coastlines in the world, is the increasing rate of sea level rise. As you can see here, the rate in the Philippines is some of the fastest in the world. And we know that if seawater intrudes into freshwater systems, people are, consuming, drinking water high in salt, or, salinized water, which can lead to a wide array of health impacts. Of course, if the flooding, the coastal flooding, becomes much more severe, then communities are facing a high risk of being forcibly displaced from their communities, from their habitats. And so I just gave to you some examples of the climate impacts on health in places like the Philippines, and I'm pretty sure you can enumerate other impacts in other places, even in the UK. And of course, right now we're all concerned about the first wave, the second wave, the third wave of COVID. I think we should be equally concerned, if not more concerned, about not just the future waves, but the future tsunamis of climate related health consequences that we can anticipate in the coming years if climate change continues to worsen. And so the question now is, are we ready to build health systems that consider the climate? Unfortunately, the health sector, right now we are talking about climate and health, but the climate and health space is still quite limited and small. Climate and health discussions are yet to penetrate broader global health agendas, including universal healthcare, which was mentioned a while ago by Richard, and the other global health spaces. And so now is a time to really put climate change front and center in the global health agenda, in the health systems agenda. And of course, it's easier said than done, as especially now as we are still grappling with the coronavirus. And I think it's important to have a much broader view and to embrace a much wider paradigm. And of course, we're all here coming from the public health field, the public health sector. But we know that we cannot continue improving the health and well being of the human population while ignoring the health of the planet, while neglecting the health and well being of our natural ecosystems. And so, this is the reason why this new concept of planetary health was born, also pioneered by a Lancet Commission in 2015. And in planetary health, I always simply say, as a physician, I now have two patients, not just the people, but also the planet as well. And so we need to start thinking about how does 21st century health system, how do 21st century health systems look like in the era of planetary health? We need to make sure that these health systems are universal, accessible to all, at no financial risk, and universal beyond borders, beyond citizenship, and making and ensuring that the marginalized, the vulnerable communities do have access to it. But also, we need to make sure that future health systems are high value. And that does not just mean high quality and safe, but also affordable and responsive, truly responsive to the needs of people. Of course, in the era of COVID, we need to make sure that our future health systems are also pandemic resistant. They can detect the next outbreak early, respond quickly, resources are available, and can lead to a better recovery. But also, as I've mentioned, we cannot ignore anymore the climate crisis. And we need our 21st century health systems in the era of planetary health to be climate smart. And climate smart is a term that is at the convergence of climate mitigation. We need to make sure we reduce our greenhouse gas emissions, but also adaptation and resilience. We want health systems that bend but do not break. We want to make sure that our health facilities, our workforce, our health systems are the last systems and the last buildings standing, when climate related impacts do occur. And so we need to flatten the curve of COVID-19 for sure. I'm pretty sure this graph is perhaps the most popular graph in this day and age. But we also need to flatten the curve of our carbon emissions, our ecological footprint. But unlike the COVID curve, in the climate curve, the Earth's capacity, unlike the health system's capacity, as we know, the health system's capacity can be enhanced, increased. The horizontal line can be elevated. More nurses can be recruited. Medicines bought, ICUs established, and vaccines being rolled out. But the Earth's capacity is constant, it's unchangeable, and therefore non-negotiable. We cannot elevate that horizontal line. There are set planetary boundaries. Richard mentioned that we have a set for ourselves a 1.5 degrees Celsius limit to global average temperature increase. And so we need to respect that limit. We need to preserve that capacity and do not we need to make sure we do not exceed the planetary boundary. And so the only curve that needs to be bent and flattened is our carbon curve, our ecological footprint curve, because we owe it not just to ourselves, but also to these children. This is a picture taken here in the Philippines late last year. Children already brought and carried in these containers to protect them from COVID, but also to protect them from the raging flooding that is driven by the climate crisis. And we also owe it to the future children of the world who are yet to be born in a warming planet, in a planet of increasing pandemic risk. And so that's it. I hope that I was able to provide a kind of a good introduction of the many challenges that we're confronting, not just only here in the Philippines, but around the world as well. Thank you very much for the opportunity.
Thank you so much, Renzo, and I hope you can see all the emoji clapping coming through. That was really fantastic. Such a roller coaster of a ride through where we are at the moment. A really good context setting for us. And thank you. And I do have some questions, but I think I'll move on to the next presenter now, and we'll come back at the end for questions. And can I just encourage people to post any questions they have for the speakers in the Q&A box on the right-hand side of your screen. Thank you, Renzo. So I'll now move over to Jess. Jess, over to you to touch on the Action for Global Health paper. Thank you.
Thanks so much, Richard. And I think someone is very kindly going to share my slides. Thanks so much, Daniela. So thank you to THET for the invitation to speak today, and of course to Action for Global Health for producing the report that I'm going to speak about, and to Richard and Renzo for the excellent presentations just now. To briefly introduce Action for Global Health, it's a UK-based influential membership network convening more than 50 organisations working in global health. And as a membership organisation, it connects and mobilises global health advocates to hold the UK government and other global health stakeholders accountable to achieve its agreed strategic goals. I'm not a staff member myself, but if anyone has questions about Action for Global Health itself, then we're very fortunate that Kate Husselby, who is coordinator of Action for Global Health, is also present in this session, and she will be able to ask any question that's about Action for Global Health's wider work. As Richard said, I'm here to talk to you today about the Action for Global Health position paper on climate change and health inequalities, and the report is of course well timed in the lead up to COP26, which is being spoken of as the most important COP since Paris, because it's the first COP since countries will have submitted their updated nationally determined contributions to meeting the Paris Agreement. The report provides backgrounds on the links between health and climate change and makes recommendations that are relevant both for the UK and more broadly. As a high-income country, the UK, of course, needs to reduce its own emissions, but also has a duty to support both climate change mitigation and adaptation in lower middle-income countries. And as the host of COP26, the UK also has a particular role to be facilitating discussions on priority issues. If I could have the next slide, please, that would be wonderful. So climate change is a threat multiplier. It exacerbates threats that are already there, and it also exacerbates existing inequalities. Health impacts are a function of exposure and vulnerability. Exposure is tied to the frequency and severity of an event, whereas the vulnerability reflects a person's ability to anticipate, resist, or cope with that event. And there are really clear inequalities and injustices here. Exposure and vulnerability are both highest in low middle income countries, which also produce the least emissions. And continuing at this macro level, high and upper middle income countries emit 86% of global carbon dioxide emissions, but also have the least exposure to climate impacts and the greatest capacity to adapt, which makes them far less vulnerable. Although the impacts of climate change on health is also increasing in high income countries, no one is immune. So in addition to colonization and the impacts of extraction on local communities, we're also seeing corporate interests at play in the way that negotiations unfold and climate policies are made, with already very wealthy actors continuing to profit. Within countries, groups of low socioeconomic status are both most exposed and most vulnerable. Older people and children are less able to respond and protect themselves from immediate hazards. Older people, especially those living with pre-existing health conditions, are especially vulnerable to the health impacts of heat. Women and men are differently vulnerable to climate impacts on account of their gendered roles, often, and they have different living and working conditions and deal with differing social expectations. People on lower incomes typically live in poorer housing or work outdoors, which leaves them more exposed to the impacts of heat, flooding, storms, and vector-borne diseases than those in often higher salaried office jobs. Next slide, please. Thank you. We'll come back to the three sectors that you see on the left later in this presentation, but the most important thing to say is that they account for the vast majority of greenhouse gas emissions globally. This is a similar figure to the one that Renzo showed, but I'm going to unpack it in a slightly different way and walk through how climate impacts translate into health impacts. So greenhouse gas emissions cause increased temperatures and changes in precipitation. This causes impacts like floods, wildfires, storms, sea level rise. These are all well recognized, and they have clear direct impacts on health in terms of respiratory conditions from wildfire smoke, injury and death during floods and storms, and limited access to safe water supply. Renal damage is also a risk due to decreased fluid intake, whether that's due to lack of suitable water to drink, either because of droughts or because of floods that have led to contaminated water supplies, or because heat necessitates the intake of more water. In addition, changing weather patterns mean that disease vectors such as the mosquitoes which spread Zika, dengue, malaria are able to breed in new locations, which exposes new populations to these diseases. And changes in rainfall also, of course, threatens agriculture and therefore food security, nutrition and livelihoods. As regions become unsafe or impossible to subsist on, communities can be forced to migrate, which then interrupts access to health services, which in itself brings new risks. Just one example of multiple impacts in a single location is the concerning Cyclone Idai, which wrought havoc in Mozambique in 2019, with wide-ranging and long-lasting health impacts intensified by climate change. In the Sofala province, 28 out of 157 health facilities were damaged or entirely destroyed. And in addition to the acute risks of flooding, longer-term impacts of cyclones such as Idai include the disruption to supply for essential medicines, such as those for HIV and tuberculosis, increased risk of malaria, dengue and cholera, poor maternal and child health outcomes, and food insecurity due to agricultural damage. Climate change is therefore relevant for all areas of global health, just as Renzo said earlier, and is already undermining decades of development gains. Next slide, please. I'd like to walk now through how climate impacts affect the three dimensions of universal health coverage in terms of coverage of people in need of care, the cost of treatment, and the care services that are available. So to link back to the impacts that I discussed in the last slide, increased burden of existing disease, such as the frequency of heat stress or infectious disease. In terms of coverage, that means that greater number of individuals require care for a particular disease or condition, and it also means higher cost because higher demand, due to higher demand. Another impact is the emergence of new diseases in a new setting. So this might be due to new geographies becoming suitable for mosquito breeding or extreme weather events for the first time. And this has implications in terms of care because the necessary expertise is unlikely to be widely available to treat those in need. Another impact is damage to healthcare facilities or of routes to them, for example, due to flooding or storms. In terms of coverage, this means that communities might be unable to access healthcare services. In terms of cost, facilities and infrastructure might subsequently be repaired, which leads to possible budgetary impacts for delivery of services. And in terms of care, if there's disruption to hospital water or electricity supply, this of course severely limits many forms of treatment. Another impact is supply chain disruption, again, for example, due to flooding or storm damage, which means that healthcare facilities that serve communities in certain remote locations may not be reachable, and therefore people needing care may be unable to receive even the most basic medicines and therapies. And in terms of cost, more complex mechanisms of delivery may be available, but only at a higher cost. And for care, even basic medicines and therapies may become unavailable. The penultimate impact I want to speak about is forced migration and displacement, for example, due to extreme weather events or loss of livelihood. such as agricultural livelihoods, and this has implications for coverage, with communities unable to access healthcare services while in transit or in a host country. And the final impact is the overall impacts of climate change, pushing houses into poverty, for example, due to extreme weather events or loss of livelihoods. And this means, in terms of coverage, that more individuals are in need due to the risk of disease associated with low socioeconomic status. And in terms of cost, those in need have even lower base funds available, which therefore increases the levels of state funding required to provide adequate care. Thank you. And next slide, please. So the need to address and respond to climate change is very clear, and both within and beyond the health sector. And the World Health Organization has developed checklists to assess vulnerabilities in healthcare facilities in the context of climate change, as well as supporting countries in the development of health national adaptation plans. And these are two vital approaches. But beyond the health sector, we also, of course, need to be supporting infrastructure to protect health in the first instance, so ensuring clean water supplies, safe housing, and maintenance of roads and their resistance to climate impacts, resilience, sorry. In the Americas during 2016, 77% of healthcare facilities were found to be in disaster-prone areas, with many health facilities following outdated building codes that were more focused on, for example, earthquake resistance, that didn't consider the impacts of climate change. PAHO is implementing a Caribbean Smart Hospital initiative, which integrates climate change adaptation, resilience, and environmental sustainability, so spanning both mitigation and adaptation. And a toolkit has been developed to support achievement of these objectives. In 2013, a severe storm cost St. Vincent and the Grenadines an estimated $2.1 million and left its only referral hospital, unable to function. Many of the 39 district health clinics were flooded, while the Smarton Georgetown Hospital remained 100% functional during and after the event. In addition to improving resilience, the Smart Hospital Initiative, as I've said, seeks to reduce the environmental impacts of healthcare, for example, through use of solar power rather than that produced by fossil fuels. Examples of mitigation in the healthcare sector also exist, like the greener NHS in the UK and others. Energy use in buildings and industry accounts for more than half of global greenhouse gas emissions. To continue on the mitigation theme, ambient outdoor air pollution from fossil fuel combustion was estimated to cause 4.2 million premature deaths worldwide in 2016, of which two-thirds of that figure are attributable to burning fossil fuels. And then there was a further 3.8 million deaths from household air pollution due to unsafe fuels and technologies for cooking, heating, and lighting. More sustainable electricity and technologies lead to reduced emissions and health benefits. To switch focus to the food and agriculture sector, both diet and agricultural methods contribute to climate change and health impacts, with climate change projected to reduce dietary diversity, leading to increased childhood malnutrition. Agriculture accounts for approximately 20% of global greenhouse gas emissions, with many of the products that are least beneficial for human health also having the highest carbon footprint, like red meat and processed foods, which are often imported over long distances and therefore have an even higher carbon footprint. Diet-related risk factors accounted for 11 million deaths in 2017. Of these, 3 million were due to high sodium intake, 3 million to low intake of whole grains, and 2 million to low intake of fruits, while another study notes that red meat contributes to almost 1 million deaths. Some ways to combat these issues would be to promote locally sourced diets that are rich in whole grains, legumes, vegetables, and fruits, and low in red meat and processed products, using climate-sensitive and sustainable agricultural methods. And finally, transport accounts for 12% of global greenhouse gas emissions, and the World Health Organization estimates that 1 in 4 adults and 80% of adolescents do not meet recommended levels of physical activity. Up to 5 million deaths a year could be averted if the global population was more active. Transport systems which are oriented to support motorized vehicles rather than active and public transport contribute to lower levels of physical activity, high levels of air pollution and traffic injuries, whereas investment in walking, cycling and public transport infrastructure is beneficial both for climate change and for health. Next slide, please. So this is the switched up version of the figure that I showed earlier, again with the same three sectors on the left-hand side: food and agriculture, energy and transport. And if we consider interventions that reduce emissions from these sectors rather than those that increase them, we see that we have cleaner air, healthier diets and increased physical activity, which in turn offer a myriad of health benefits and therefore have high returns on investment. And just to quantify these health benefits a little bit, according to research by the Lancet Countdown on Health and Climate Change, alignment of policies in the energy, food and agriculture and transport sectors to the Paris Agreement would yield not just reductions in greenhouse gas emissions, but also a reduction of 1.8 million air pollution related deaths, 5.8 million diet related deaths, and 1.2 million deaths due to physical inactivity, and that's in just 9 countries by 2040 every year. Next slide, please. Participation is a really key way to be thinking about how these interventions can be developed and implemented. People who are most affected, particularly those who are vulnerable and experience multiple and intersecting forms of discrimination and oppression, must not only be engaged in a tokenistic way, but meaningfully engaged and prioritised for active outreach, decision-making and control over resources. And this should come in the form of coalitions, awareness and transfer of power, including knowledge and information, dialogue, gathering of disaggregated data, financing and ensuring an inclusionary approach with those with lived experience, ensuring the most marginalised have a meaningful seat at the table at all levels. Next slide, please. This is my last content slide. So the position paper makes 10 recommendations. As I said, these are intended to be global in scope, but are also relevant for the UK. Right now, every country needs to reduce its own emissions across sectors, but the UK also has a duty to support lower middle income countries to mitigate climate change, because we need every country to be mitigating climate change. But crucially, these countries also need to be supported to adapt to climate change in the short term, as well as will also be the case in high income countries in the future. So to run through these recommendations, climate resilience must be considered as part of health system strengthening. We also need to build climate-sensitive healthcare sectors which mitigate their greenhouse gas emissions, to strengthen infrastructure beyond the health sector, but also for health, to facilitate a just transition to renewable energy, but crucially protecting livelihoods and ensuring a just transition for everyone, to protect the most vulnerable communities, to promote healthy and sustainable diets rich in plant-based food and lower in processed foods and red meats, and to be promoting the integration of active transport infrastructure alongside public transport to minimise emissions and air pollution and ensure safe and equitable connectedness for all. Countries need to renew commitments to the Paris Agreement and ensure consistent reductions in emissions on an annual basis, but crucially also to provide financial resources to assist climate change adaptation and mitigation. Financing will be a really key discussion at COP. High-income countries committed $100 billion every year to support low middle-income countries, but we're still $20 billion short of that figure. COVID recovery was hoped to provide opportunities for both climate change mitigation and adaptation, although this hasn't been evident in all countries. Number 9, activities must be researched, planned and implemented using an inequalities lens. And finally, national platforms must support cross-sectoral coordination to ensure integration of health across climate change mitigation and adaptation priorities. And that's all for me. Thank you so much.
Thank you so much, Jess. That was really fascinating, and well done for distilling such a detailed report into 8 slides or so. That was so helpful to see. And it would be really useful towards the end if we discuss those recommendations in a bit more detail on how they apply to health partnerships and health workers who work in them. So I'd like to move on to our final speaker for now, to Dr. Elizabeth Tissing, who's going to talk about her partnership experience with the King's Global Health Partnerships. Over to you, Liz.
Sorry, just bringing up my slides. I'll be with you in a minute.
That's all right.
There they are. Yeah, so I'd just like to talk, I suppose, slightly more practically and maybe in a bit more detail about some of the work that we've done in Congo with our partnership. I am not a climate change or a climate health expert by any stretch of the imagination, and I've been educating myself or trying to educate myself over the last couple of years or so. So this is me coming at it from a slightly more practical standpoint. So the King's Congo Central Partnership is one of 4 partnerships from King's Global Health Partnerships, and we're partnered with the Provincial Ministry of Health in the Congo Central province, which is southwestern DRC, and it's a population of about 6 million people. One of the areas that we've really focused on is on safe surgery, and this phrase that saves surgery saves lives. We know that 4.8 billion people in the world do not have access to safe surgery, timely surgery at the point of need. The WHO's response to that, or one of the responses to that, is this WHO document, which is now slightly dated, but I think is still important. And it's entitled Safe Surgery Saves Lives. And there are 10 pillars within that, and 10 ways that we can contribute to making surgery safer, particularly in low resource settings. And those are simple things like swab counts, control and the way that waste is disposed of, particularly sharps, the WHO checklist, which many of you may be familiar with, the use of SATS probes, and also issues around data collection and data management for surgical outcomes. So this document, I think, encompasses some practical steps that we can take to improve surgery. And it's something that we've been working on since about 2017, when we introduced the first kind of program of work, and we're working with the 4 main hospitals in the province to introduce these elements of safe surgery. Really the recognition that surgery is an integral part and a fundamental part of good healthcare, and that without the provision of surgery, you are lacking a fundamental element in the provision of healthcare for your population. We also know that surgery contributes quite significantly to climate change. And surgery, particularly in high income settings, is really catastrophic, I think, for the environment. And this is just one paper that I'd like to discuss and mention in that context. This paper looked at carbon footprint of operating theatres in the US, in the UK, and in Canada. And they synthesized this information together. This is from a couple of years ago. And they found that theatres were 3 to 6 times more energy intense than the hospital as a whole. So hospitals as a whole contribute significantly to climate change, but theatres in particular are really energy intense, mainly due to heating, ventilation, and air conditioning requirements. I stress again, this is in a high resource setting, high income setting. They found that overall the carbon footprint of surgery in these 3 countries, so the US, the UK and Canada, contributed an estimated 9.7 million tonnes of carbon dioxide equivalent per year. Clearly this is not sustainable. Clearly this needs action. Clearly the system needs to change, and clearly something needs to be done to improve this situation in high income settings. We can't continue at this level and in this way. So really our question became, how do we scale up surgery? How do we build on a safe surgery program of work without contributing to the climate crisis? And this is something that I've wrestled with for the past couple of years or so, and in part actually triggered by the UK PHS call for funding applications with that climate change funding stream. So this really started a journey for myself, for our team at King's, and also for my Congolese partners to discuss together, how do we do this? How do we go about scaling up surgery without contributing to the climate crisis? One of the very early things that became, I think, apparent to us all was low resource theatres operating environments don't need to go green. They are green already. They are green really most of the time of necessity. So on the right-hand side, you see one of our surgical colleagues, Papa Nico, in the operating theatre, and you can see the light that's streaming in. So natural light, lots of windows, which you can see all the way over on the left-hand side, the main front facade of the hospital, lots of natural ventilation. So you've immediately eliminated that high energy usage because you have natural ventilation, no heating or cooling in operation, and using natural light. So on that side, this operating theatre is already essentially green. I don't think it's all the way safe, and certainly very much needs to be done to improve its safety. But on the green side and on its contribution to carbon emission and to climate change, they're doing really well. One of the other elements that we looked at was water usage. Theatres are really intense in water usage. And you can see here that we've got a really simple hand washing station that doesn't rely on running water. So this conversation is still being had. This is where we're at the moment. How do we scale up surgery? How do we make surgery safer? How do we ensure an adequate supply of energy, of electricity, and of water when it's needed? But doing so in such a way that's sustainable and doesn't contribute to climate change. We did lots of reading. We tried to find some useful frameworks. One of the frameworks that I thought was helpful was thinking about the building blocks of health systems from the WHO. And they've added an additional circle around the outside of that little diagram to incorporate the climate resiliency element of it. So we tried to think about some of that. What is it about the surgical element and the theatre environment that we could fit into this? One of their other reports divides it up into 4 sections. So thinking about the health workforce, thinking about water, sanitation, hygiene, and waste management, and then thinking about energy usage and about infrastructure and technology. So again, a framework that we tried to grapple with, how do we make sense of what we're doing in surgery and in the hospital environment and the climate crisis. Another really helpful framework, I think, is from John Meara's group in the US, who have looked a lot at national surgical obstetric and anesthesia plans. And they've tried to see how we can mitigate and adapt, phrases that we've heard about already this morning, how can we mitigate and adapt in the surgical space. So they've got 3 levels there, so operating rooms and facilities, academia and professional associations, and then also national health systems. I have to say it's a challenge to take these frameworks into something practical, and the task seems to me enormous and a little bit overwhelming, if I'm really honest. I've tried to apply a slightly surgical, practical outlook to this, and so we've started small, and I just wanted to talk about a couple of things that we've done so far that we'd really like to build on. And things that we really had hoped to build on with some of the UK PHS funding, which sadly is no longer. So this energy usage and provision, one of the things that we've been thinking about is that we really want to maximize what is good. So maximize the learning from our in-country partners. So continue to use natural light, natural ventilation, minimize water usage. And yet we do need to do something to improve the situation. So one of the key, obvious, I think, starting points is to think about solar energy. One of the big obstacles that we've come across is that it's actually very difficult to quantify the energy usage of this particular hospital. This is the tertiary referral hospital in Matadi, where we work in DRC. And there isn't, because electricity supply from mains is really intermittent and unreliable, there isn't actually a valid or accurate record of how much energy is currently used and how much energy might be required for this hospital to function at full capacity. So that's something that we're working on and hoping once we've got that good baseline assessment to think about the installation of solar panels to provide a more reliable but also sustainable energy source. The other thing that we've been working on with an organisation many of you may know, Medical Aid International, is their EcoClave system. So introducing better sterilisation services, but doing so in such a way that doesn't contribute to more electricity usage, but a way that's sustainable using the EcoClave. Water I mentioned, again, because we're not able to quantify water usage in the hospital, it's very hard to know how to best implement that and how to scale that up. And then the other intervention that I wanted to mention, the other stream of thought that we've been thinking about are supply chains for some of the materials that we need and some of the materials that are used in surgery. And I'm talking here specifically about orthopedic surgery, which traditionally has been quite resource intensive. So on the left, you see the very first 3D printed foot ankle splint printed in Kinshasa a few months ago. And this is an initiative with a number of different organizations, one from Belgium, one from the DRC, ourselves from King's, working together to figure out how to best implement and use technology, current technology, to solve some of the supply chain issues that we have. And then a paper that we worked on, colleagues in the DRC and some colleagues at King's College Hospital, we looked at cobalt and its mining in the DRC. You may well be familiar with some of the mining practices that happen in the Eastern DRC, and also the huge contributor that the DRC is to our global supply of cobalt, coltan, and other minerals. The crucial thing about cobalt is that it's used in many orthopedic implants. And so we've explored together the inequity that is found in global supply chains of cobalt. So the way that it's mined is not ethical, and the way that it's used as a resource is highly unethical. So those are just a couple of things, practical ways that we've been exploring together as a partnership about how we might scale up surgery sustainably. So make surgery safer, make surgery accessible, but to do so without contributing to climate change. And be great to hear discussions and other people's thoughts on this in what is for us still really a work in progress.
Thank you so much, Liz. That was honestly so great to see from my perspective, a health partnership really tackling with this issue. And as I said at the start, we didn't know who was looking at this at all until we started developing this conference talk. So it was so good to see real tangible ideas coming from you guys, and also the very interesting point about that theatre is already much greener than anything we know in the UK. So yeah, how much emphasis should we as the Global West be putting on this when we work with overseas colleagues? So thank you so much. I think there's a few questions in the Q&A. So if we can, have all panelists back. And the overarching question is, okay, so what can health partnerships do? But I'll slightly tweak it to each speaker, if that's okay. So Dr. Renzo first. So you were talking about how it's important for the climate crisis to be front and center of any kind of global health discussions. The world that FET operates in with health partnerships, and the people on this call are most likely to be health workers, clinicians, academics. So what can they as individuals do in that very big picture that that big challenge that you're setting us?
Well, thanks for that question. I think the first step is really, an understanding of the interconnectedness of these myriad issues, how the health of our patients are connected, is connected with the health of our planet. There's actually a question about, the concept of planetary health, difficult to explain, when in fact the concept of planetary health, while I mentioned a while ago that it was somehow, introduced or maybe reintroduced a few years back, this idea that the health of the planet and the health of people being inextricably intertwined is not an original invention. We return to indigenous wisdom, to the wisdom and knowledge systems of indigenous communities, And for millennia, they have already acknowledged and recognized the health and human health and environment health nexus. And so I think that requires understanding and learning and relearning and perhaps unlearning of many things that we have been espousing in medicine and public health. And I actually got thrilled listening to Elizabeth, because now you're trying to bring climate change and planetary health into surgical systems. A few weeks back, I actually spoke in a panel on the sidelines of the UN General Assembly on this very subject. How can we create climate smart NSOPs? NSOPs, surgical, obstetric, anesthetic, and trauma plans that consider the climate, not just in terms of lowering our carbon footprint, but also making sure that these services are available, especially to climate vulnerable communities, and that their provision will be uninterrupted when a typhoon or an extreme flooding or a heat wave does occur in a particular location. So I think there's a lot of opportunity. I would love climate and health to be embedded in the discussions of every clinical specialty. Because as I've said a while ago, there's no single disease group that is immune to climate change. Everything will be affected, unfortunately.
Great, thank you, Renzo. I'll move on to Jess now, and I know that Jess, you're interested in the health partnership world interacting with other sectors as well to tackle this. So again, a similar question, but how do you see coordination between health partnerships and other sectors working towards this goal?
So I've been looking quite a bit at nationally determined contributions recently, and they've been mentioned a couple of times in this session, but NDCs are each country's commitment to reduce its greenhouse gas emissions in line with the Paris Agreement and to respond to climate change. And a number of NDCs, I think probably about a third of the ones that I've looked at, do include the health ministry in the planning of that nationally determined contribution. So the health sector is integrated as part of multi-sectoral coordination, which is really encouraging, and you do see stronger integration of health throughout those nationally determined contributions, both in terms of mitigation and adaptation. The World Health Organization is also working with specific countries to look at how health complements mitigation and adaptation, and for example, in the energy sector, the transport sector, and the food and agriculture sector, as well as healthcare adaptation itself. And finally, I think it's useful to just highlight one example of how financing can be linked to both health and climate change. And this isn't an example from a nationally determined contribution, but about 10 years ago, and it's still the most interesting example I've seen of this, Indonesia started to phase out fossil fuel subsidies. But rather than seeing the protests like there were when France changed its fuel pricing policies, rather than there being protests like the Gilets jaunes, Indonesia decided that it was going to feed those subsidies instead into healthcare to make it more affordable for the most vulnerable people. So it built support for that fossil fuel subsidy reform, which I think was a great way to do things. I'll pause now because I know we haven't got too much time left, but they seem worth highlighting.
Thanks, Jess. No, that's really interesting to bring in other players there. And I'll move on to Liz. Similar question, but I was really struck by when you talked about the frameworks that WHO have and how they were useful, but not enough kind of for what you needed. And so what do you think health partnerships or indeed THET can provide to get you guys to that next level? What extra is required there?
I think it's complex because it's so interconnected, and this kind of climate crisis, climate change is really interconnected. It's complex, so it's not easy to put it into a simple framework. I think that's the first thing. So I don't want to be overly critical and overly judgmental, because I think it's hard to stick this into a framework, and it's hard to put it into a framework that's really practical and tangible and useful. I don't judge anybody for that. It's the way it is. So I think the first thing we need to do is just be a bit gracious with each other and say, this is a framework we've developed, use what works. If it doesn't work, adapt it, tweak it. And I think that's okay. And I think we just need to have many more conversations together across disciplines, So for me to listen to people talk about climate change, which I ordinarily wouldn't do, and perhaps for people to listen to clinicians talk about surgery, which they ordinarily might not do. So I think we need to have many more cross-discipline conversations to come up together with frameworks that are practical and beneficial and work. So just much more of that kind of multidisciplinary across sectors discussion. I think the other really important thing for me is we need to do a lot more listening to our partners who work in low resource settings, who are disproportionately affected by climate change and the climate crisis, and also who for years and for decades have lived in low energy usage environments. So I need to do very much more listening to my Congolese colleagues. I need to do very much more watching and seeing how a hospital with a low carbon footprint, what did they do? You know, what is it about that hospital that makes that work? Their natural lighting, their ventilation, their water usage. I don't want to come in with my agenda and say, hey, for surgery to be safe, you must have electricity 100% of the time, and you must have running water 100% of the time, and you must use these sterile swabs in this way. I think that's totally wrong. It's not going to get us anywhere. So I think we need to do much more listening to people who work in those environments, keep the good, and build on that together. I think we're not gonna make progress if we come with an agenda and try and bring everybody up to the same that sort of level. I think that's not going to work. So yeah, for me, the kind of cross-discipline discussions, conversations, frameworks, and then really listening to our colleagues and our patients and our co-workers who have been in those low resource environments for decades. You know, what do we have to learn from them? I think that's how we're going to make progress and tackle this huge challenge together, because it's an enormous challenge we face.
Absolutely. Yeah, thanks, Liz. And if I could turn to a question we've had from Dorcas, which is around behaviour change, and it's open to anyone who'd like to come in. I don't know if everyone would like to, but so how can we promote behavioural change and measure the impacts of this behavioural change in planetary health and health systems? Open to anyone who'd like to come in on that.
Yep, I'll jump. I think what we need to do as a health sector and as health professionals is to model good behavior, right? And of course, during this pandemic, we've seen how the health sector, health professionals have been, very, what's the term? Quite respected and listened to. And so if we actually walk the talk and we show that we have a health sector that is not just responsive to the needs of people in a warming planet, but also lowering its emissions through many different ways, from the way we use our energy, to the syringes that we utilize for the vaccine rollouts, to the way we feed our patients in our hospitals. I think that will signal to the other sectors that such good behavior is being practiced by the health sector, by THET and other organizations, and the hope is that they will follow suit. I also think that one is role modeling, but number two, we need to kind of nudge each other to and pressure each other to actually embrace good behavior that is compatible with planetary health principles. And so I think that's it, and there might be some carrot and stick dimension to that, right? You be a role model on one hand, but also you kind of add some pressures and nudges to your colleagues with the hope that eventually we'll all reach the finish line of a healthy and green, post-COVID future. I'll stop there.
Thanks, James. Liz, were you coming in there?
Yeah, I think individual choices and individual behavior are important, but I also think that so much of what happens in a large part of the world happens of necessity. So my colleagues in Congo aren't making a choice about whether to be green or not. They can't switch the light on because the mains have been cut. There is no electricity today. And so of necessity, it's going to be a day with no electricity and no energy usage. So I think, I'm still figuring out what the best way to structure that and frame that is. And my impression is that for many places and many hospitals, the choices individual makes, are going to have a fairly limited contribution to the picture as a whole. I think it's really about what can we do at a system level at this stage to improve the situation. I think if you're talking about me personally here in the NHS in the UK, again, my individual choices that I want to put this wrapper in the recycling bin, there is no recycling bin anywhere close to any of the clinical spaces that I work in. So I think, yes, individual behaviors are important, but I think the system as a whole also really we need to do very much more to improve our systems.
And if I can just build on that comment by Liz, if we're talking about policy change as a systemic version of behaviour change, then I think health is an incredibly useful and valuable narrative to achieve that, because I think for a large proportion of the world's population, climate change is still about polar bears in the Arctic. It's not about our health as individuals. And the more that people in charge of policy realise that and the implications it has for them and their families and their populations and not for far-off lands, then I think the more progressive policy making we're going to see.
Yeah, absolutely. Thank you. Okay, I realise we've run over time, and this is so interesting. I wish this could carry on longer. What we'll do is, I really liked Lisa's question at the bottom there, and I think that's quite a good way to end, which is I'll ask each of you to say, what is the one thing health partnerships could do today? While you're thinking of the answer, Charlotte, could we put that poll up? I did say we try and have a bit of interaction. So we're just going to ask you guys to vote on where are you with how your health partnership could, you're thinking in terms of getting involved in climate crisis, resilience, adaptation, or mitigation. So are you currently working on it? Is it within your scope, but you're not quite doing anything yet? Or have you not yet considered it? I feel like anyone here, we're preaching to the converted a little bit if you've chosen to come to the session, but it'd be really interesting to know where you are kind of on those three tiers. So if you start filling out that poll, and I'll come to my speakers just to answer that final question. So what is the one thing health partnerships could do today? So if I go to Dr. Renzo first.
Yep. I guess the low-hanging fruit is to make sure that this is not the last conversation on climate and health within your organization. And it's not just about coming up with new innovations on climate and health or tackling climate and health, but to actually examine all your operations through a climate and health lens and see and identify potential entry points for action. Thank you very much for this opportunity.
Thanks, Renzo. Over to Jess.
I think for me, it would be about including health in climate narratives in the lead up to and at COP26 itself. I think there's already exciting partnerships kicking off between sectors in that regard. And Action for Global Health is a member of the Health and Climate Network that sits within the Wellcome Trust. And that's a really excellent example of coordination between the energy, transport, food and agriculture and health sectors. And there are specific recommendations that come out of that.
Thanks, Jess. And yeah, we'll be following up with Action for Global Health over the next few months to see how we can push those recommendations from the report. And last but not least, Liz.
Although I am very keen for action and I think it's really important to do stuff and I would like to do stuff, I think one of the things that we really need to do is do listening and to spend much more time listening, particularly to our co-workers who work in challenging environments. I think we have a tendency to rush in a bit too quickly to do stuff. And I think this is an opportunity we have to really listen and to properly listen and then move forward.
Fantastic. Yeah, a wide array of responses, but all, incredibly valid. And I think, Liz, I'm with you in terms of, I feel and FET feels very new to this area, but we shouldn't be, but we are. We need to a lot more learning and a lot more listening, as well as acting. So thank you so much to our speakers. That was a really terrific session. Charlotte, I don't know if we can see the poll somewhere. The results from the poll. If not, then maybe I will look at it later. Okay, I don't think it's coming through unless other people can see it. Okay, well, let's leave it there. But thank you so much, everyone, for your time. This is hopefully the start of a longer conversation that FET will help coordinate with the Health Partnership community, and we'll take from there. But thank you very much. We've got another session at 12:30 to finish the final session of this year's conference, and I look forward to seeing you there. Take care.